Brian took time out of his busy schedule as the program chair for the whole meeting to talk to us about endoscopic electrosurgery. Thank you very much. Thank you. Forward, and this is your little
pointer there.
Yeah.
Okay. Well, good morning, everyone. It's a pleasure to be on the podium as part of this inaugural event for the FUSE program. We're pretty excited about this in general and happy that you're part of it. I am a surgical endoscopist in my daily practice, and I was asked to give a talk about flexible endoscopy devices around energy. And I want to emphasize during this talk, even if you're not an endoscopist, most of us are general surgeons that are often asked to deal with complications related to the use of energy in endoscopy, and so it's important to understand how those things occur. By the way, I have no disclosures that are relevant for this talk. So I'm going to emphasize some of the unique aspects of endoscopy and the tools that are used in that environment, and then also describe some of the special devices. And one thing that's interesting to note about endoscopy is, in comparison to surgery, where surgeons are kind of 30-30 people, right? 30 of cut, 30 of coag, and let's go to work. Endoscopists actually vary their energy level depending on what part of the GI tract they're working. However, they don't often understand exactly what those settings are and often rely on people around them. And so you'll see that sometimes that's misapplied, and that's often when we get the call about perforations or bleeding. So I always emphasize, and I know this has been emphasized through the morning, that you need to know your hardware. In fact, as the clinician in the room, if you're a surgical endoscopist, you need to know this stuff better than anybody else in the room. And you need to check it as well before you use it. You've heard a lot today so far about monopolar and bipolar energy, and that's the same stuff that's used in the endoscopy suite. It's just that the tools look a little different. Most of us are familiar with a snare or a hot biopsy forceps. You may not realize that things like that Stretta catheter, that's a monopolar device, or the argon beam that's used in the GI tract is also a monopolar device. Likewise, we have bipolar devices in flexible endoscopy. Most commonly would be this device, which is a multipolar electrode, also known as a gold probe. That's a bipolar device that we use frequently for managing bleeding in the GI tract. And if you're a foregut person who deals with Barrett's esophagus, you've become familiar with this device, which is to ablate mucosa. As in all procedures, things start with patient preparation, but I'll tell you the endoscopy unit's a little unique. Most of our endoscopy units are open units, which means that a person can show up on my schedule for a screening colonoscopy that I've never met before they showed up that day. So I need to make sure the bowel prep is adequate, not only for my visualization, but also that we don't have gases built up in the GI tract that can be a danger. I need to understand how to deal with rhythm management devices on the fly. I don't have the luxury of having them go down to the rhythm management lab to query that device ahead of time. We need to be a little bit more interested in placement of our dispersive electrode. Patients are also often partially clothed. Maybe there's some limitations. Maybe we don't understand exactly about where their prosthesis is from their hip surgery. So you have to think about that. And jewelry is a factor as well. That's not screened out by kind of your pre-op area, and you may have to be more aware of it. Let's talk a little bit about specific areas. Polypectomy, clearly the most common area for using electrosurgical energy in the GI tract. You've heard a lot about the physics of energy this morning and energy density, and that comes to bear in this scenario. So I'm trying to maximize my energy density at the base of that polyp so that I get the effect that I want to excise it. And I do that by tightening my snare around that base to increase the energy density there. There is data to help guide us on what kind of energy to use for removing polyps. For instance, cutting current has the highest post-polypectomy bleeding rate. And so we don't use pure cutting current for polypectomy. We usually use coagulation current. Blended current is also an option, and those seem to have the same rates of post-polypectomy bleeding in the literature. There is a mode called endocut, which is rather unique to the Ercp system, And this is one that many endoscopists, medical endoscopists, are familiar with ERCP because it's used for sphincterotomy. And it's now, because of that familiarity, being brought often more times into other tissue resection. It's actually a nice mode of energy. It starts with kind of conceptually almost like a blended current with cutting and coag features that gets you started on tissue division, and then it alternates between these bursts of pure cutting and coagulation. And what that does is it gives you a clean division effect with little eschar but good hemostasis. There are some things we want to avoid. So in a pedunculated polyp, you can get direct coupling to the wall opposite of the colon, and you didn't even think about that. So here's an example of a pedunculated polyp. Snare is tightened here, and we're getting that energy density effect that we want, but this polyp is resting on the colon wall over there, and you can directly couple energy to that opposite wall. If you're not cognizant of that and you just leave the polyp sit there, you'll get thermal damage to that opposite wall that could lead to perforation. So you'll see us jiggling that snare back and forth, moving that polyp so that it doesn't touch the opposite wall in any one spot for any significant period of time and minimize that direct coupling. We also have other strategies like elevating a polyp so that you get a mucosal tent that keeps you off the muscularis mucosa, or inject into the submucosa to raise flat lesions so that we have this cushion of fluid to protect us from the muscular layer. And this is the sclerotherapy needles that we use to do that. It's important to have someone on the other end of that snare that knows what they're doing. The application of energy for polypectomy has to be done in the proper way. You don't want to tighten that snare too quickly. You can actually have a cold guillotine effect and take that polyp off without delivering any energy to its base. And likewise, you don't want to do it too slowly because then you just get this constant spread of thermal energy and that zone increases and you can get more collateral damage. This is so important that some endoscopists actually switch to having the nurse hold the scope during the closure of the snare, and they put the snare in their hand as they're delivering energy. Hot biopsy, there's a little controversy in the GI world about the utility of doing a hot biopsy, but if you're going to do it, we do it by, it's used for small sessile polyps, grabbing them with a hot biopsy forceps, which is just a monopolar forceps, tenting up the tissue, and then applying short bursts of monopolar energy until you see the kind of snow running down the mountain, as we say. You see the coagulum at the base. The idea is that you get a tissue sample that tells you what kind of polyp this is, but you leave behind an ablation zone that will destroy any residual tissue in the area. It's a nice theory that's been brought into question lately. Post-polypectomy syndrome, most surgeons have dealt with this. This is when you get called for that patient that had a polypectomy earlier in the day, usually returning to the emergency room a number of hours later with, for all the world, signs and symptoms that would suggest that they have a perforation. This is not a free perforation. This is a full-thickness thermal injury to the wall of the colon that's led to local peritoneal irritation. It's best investigated by a CAT scan to demonstrate that there hasn't been free perforation, and these patients almost universally can be managed supportively, usually with antibiotics and bowel rest, and they will resolve. So try not to run to the operating room with patients with that syndrome. Bleeding is another common thing where we use energy. I mentioned this probe. This is the multipolar electrocoagulation probe. Very nice to have in our toolkit because you can hook it up as a bipolar probe to really any generator in the hospital. We also have this unique device, which is not electromechanical energy. This is heating energy, and it's called the heater probe. It's actually kind of my favorite device, although it's harder to get a hold of them. This is a Teflon-tipped probe connected to this device that delivers a certain number of joules of energy, and it does that through that foot pedal activation. It also has water irrigation. We apply the principle of coaptive hemostasis. It sounds like you've heard about that also earlier this morning, but when you're stopping bleeding in the GI tract, it's not just putting a little cautery on the area and trying to stop that. We actually will wash away any overlying blood and clots so that we can see the base of that ulcer, look for a dark spot, which is usually fibrin deposition in the wall, or active bleeding. Actually, if I see active bleeding, I'm the most happy, because I've located the lesion and I'm confident that I'll be able to stop that. So I need to get that clot off, see what's underneath, and then we apply either our multipolar probe or our heater probe perpendicularly, if possible, and directly to that so that the walls of the underlying vessel are coapted together. Then when we apply heat, it seals those walls together. Here's an example in the experimental lab to demonstrate the technique. This is using a heater probe, but you could use the same with a gold probe. You can see the irrigation features of that. The jets are actually, please turn off the sound on that if you could. The jets are actually back from the tip that allows you to actively irrigate while you're applying heat. Here's a little explanted bowel, and we're going to use one of the mesenteric vessels for our example. Make a small hole in that. That's the base of our bleeding ulcer that we're going to manage now. And we'll bring the heater probe in here and actively irrigate to very clearly localize the site of bleeding. Once you've done that, then you apply the probe and you see if you've stopped the bleeding. And if you have, then you know you're in the right spot to apply your coaptive hemostasis. So you can reposition a couple of times to do that, and you'll see that here. And then once you've decided that you've done it, and you've stopped the bleeding and you're coapting the vessel, then we simply push on the foot pedal and deliver that energy. If you've seen this done in the stomach, you will be amazed. We will do 4 sequential ablations that will give us a crater that's almost a half a centimeter deep. It's scary if if you haven't seen it before. And then we literally irrigate ourselves off the lesion so that it separates without pulling off our coagulum. We heard about argon. Argon plasma coagulation, very useful in the GI tract for managing superficial lesions. This is non-touch application of energy. This is monopolar energy, grounding pad, argon beam, and away we go. Basically using that argon plasma, which is really an interesting concept, isn't it? Using a gas to conduct electricity. And so this is a nice modality for painting surfaces, radiation proctitis, arteriovenous angioectasia, little bursts of energy, very superficial application, unlikely to get a deep thermal injury. You got to remember to aspirate the gas. We're working in a closed environment. This isn't like an open abdomen or even in laparoscopy where our insufflators will actually auto-adjust to the increased pressure. That doesn't happen in the GI tract. So the endoscopist needs to be cognizant of the flow that they're using for the argon and then aspirate that back out. Ercp, as you know, we do all kinds of things therapeutically with Ercp. Creating a sphincterotomy is one of the most common things we do for therapeutic Ercp, and that's typically with monopolar energy. There's the cutting wire on what's called a pole sphincterotome. You can also use this device, which is a needle knife sphincterotome. A little scary to some endoscopists, but we use that to make a freehand cut for some difficult situations where the pole sphincterotome isn't applicable. This, in the GI world, is where Ercp has been used most often because of the endocut feature. When I teach fellows, one of the things that we're most concerned about is what we call a zipper cut. So we get the sphincterotome into the papilla, we position it properly, and they push on the foot pedal as if they've got tetany in their leg. And the energy just goes zip right up, and the next thing you know, you're looking at the retroperitoneum. We don't want that, and one of the things that this device allows us to do is we get this controlled small burst of cut, coag, small burst of cut, coag, which gives you a very nice controlled sphincterotomy, and it's why many endoscopists have moved to that device. Finally, I just want to say a couple of words about special devices. I mentioned this. This is the halo ablation system for ablating Barrett's esophagus in the esophageal mucosa. This is simply bipolar RF energy, and it's a balloon-based electrode array that's mounted on the end of that scope, and this device has really transformed how we're managing Barrett's esophagus with dysplasia, and you're going to see more and more patients treated with this. If you haven't seen the device used, here's a little water tank demonstration of the firing of the device. Once we position it and I push on the pedal, literally that quickly I have a 3-centimeter circumferential ablation of the mucosa that looks like this. And so there's some very good data now on this, and in fact there are a number of sessions at this meeting that talk more about use of that type of device. Stretta is a device that's come back onto the market. This is a device for treating gastroesophageal reflux disease. These are electrodes arrayed around a balloon. Very sophisticated device. There are thermocouples, so it actually measures the temperature that's being delivered. We try to get a delivery of temperature into the muscle in that 80 degrees centigrade range and keep the mucosa cool below 50 degrees so we don't damage that. And it's a series of treatments around the area of the lower esophageal sphincter. And again, this is back on the market now, so you're going to see some more applications of that device. Finally, some special tips. In endoscopy, we need to be careful that the entire device is exposed in the lumen, not partially inside the working channel of the scope. I don't want that metal to be inside the scope, because when I apply energy, it will either damage the scope or I have the potential to directly couple to something else in the area that I cannot see. So when doing endoscopy, make sure the entire device is out in the lumen. If you've got other stuff in the area that conduct electricity, like these endoscopic clips, we want to be careful not to be applying to those devices and accidentally directly coupling again. And finally, when we're doing polypectomy, I mentioned how important it is to control the snare. We don't want to bury that snare in a bunch of fluffy tissue. Now I'm not getting that energy density at the base of the polyp anymore. I'm conducting the surrounding tissue as well, and I'm going to get essentially an unattended direct coupling to other tissue in the area. So again, emphasizing some of the unique aspects of flexible endoscopy and the tools that we use in that environment, just to give you a little overview of how you should be using those devices if you're a surgical endoscopist, and how you might encounter patients that have had those devices applied to them if you're the surgeon called to manage complications. Thanks for the attention, and I'm happy to entertain questions during the discussion period.